So now have a good look. What is the situation here? Well, what you see here, the ischial valgus is not there. The acetabulum is quite competent. The teardrop is an important sign. If you have a teardrop, it means that the femoral epiphysis is present. In this situation, we felt that the femoral epiphysis was present. How could we confirm? We did an MRI. So this is a few months after this, and this 4 months after the episode. 9 months after the episode, the femoral epiphysis is now visible. So this is way back in 1991, and this is in 98, 3 years later. The femoral epiphysis is occupied very well. And this is in 2010, 20 years later, you find a good femoral epiphysis, and this girl is a very accomplished dancer. Now, what is the situation here? Is the femoral head absent? Well, most would think yes, the femoral head is absent, and we should give a particular form of treatment. It's not so. We just do an internal rotation view, and you see that the femoral epiphysis is present. It's shown on the MRI, the femoral epiphysis is present. So rotation views are sometimes very, very helpful. You see that there is gross antiversion here. The femoral epiphysis is pointing forwards because of the gross antiversion. Only when you rotate the femur do you get the head in true profile. So what does this need? This will need a derotation osteotomy. That will be required for this particular patient. Also the problem of multiple involvement in hip sepsis. This child, as you can see, all attention was focused on this side. There is dual involvement. Both the hip joints are involved. There is sepsis bilaterally. This is the sequelae infection here. This hip appears completely normal. This was in 1979. And 20 years later, you find a problem with the right, not the right. She's doing very well on the right side with the left hip. With the opposite hip, which was all along thought to be not highly involved. So multiple bone or joint involvement is very common in hip sepsis to an incidence of 40%. So now let's look at decision taking in these cases. Group 2, I'll focus my attention solely on a situation where the femoral epiphysis is absent. What are the clinical problems when we are faced with the situation of sequelae of sepsis? There can be 4 clinical problems. You could have either an unstable hip, like happens in group 2. You can have deformities, flexion deformity or adduction or an abduction deformity. You can have hip stiffness, or you can have a problem of shortening. Shortening problem affects all the groups. Now what are the solutions in these cases? When we talk about group 2, an unstable hip, you have problems of instability and shortening. They are highlighted here, and let's see what we can do for these cases. So what are our treatment options? We can leave them alone. Faced with the excision arthroplasty type of hip, you could leave it alone. You could do one of the trochanteroplasties like the Harman Leviscopo procedure or a columnar type of trochanteric arthroplasty. You can do a Shaz angulation osteotomy, or you could do Elizardo hip reconstruction. Leave alone is an excellent option, but it does not solve the problem of lurch and unstable gait. Now we compare 2 series, one of which was treated and one of which was left alone. The left alone series actually fared better. They had a Larson score of 94.9 compared to those who had a trochanteric arthroplasty. They had an inferior score 78.5. However, there are still problems. What about future reconstruction? Trochanteric arthroplasties have been proposed. Leviscopo in 1936 bifurcated the upper end of the femur and turned the inner part into the acetabulum. Harman did the same, utilizing bone grafts. Bone grafts were kept to force the medial part inside the acetabulum. And then a very ingenious way has been described by Israeli surgeons in the 1980s. And this is rotation trochantroplasty, where the trochanter is rotated inward. So you turn it 180 degrees, and that's contained in the acetabulum. So these are all different ways. When you do a trochanteric arthroplasty, there are a lot of advantages. The hip joint becomes stable. Normal bed bearing encourages development of the femoral shaft. It diminishes linear discrepancy. It allows for femoral lengthening and makes for a potentially good socket for a later joint replacement. However, there are a lot of disadvantages also. You have restricted range of motion. What you are putting inside is not a normal femoral head. It is not round, it is not spherical, so you have restriction of range of motion. You can get ankylosis because of wear and tear. You can get pain, degenerative changes, and repeated subluxation because your abductor mechanism is poor. It's said that the best results are before the age of 5. I show you a 12-year-old boy. with this group 2, loss of the femoral epiphysis, and he had a trochanteric arthroplasty. This is a 1 year follow-up. You see good remodeling of the trochanter, and what is happening over a period of time is a gradual subluxation because the abductor mechanism is not good. So he had a repeat surgery. He had a cardiac osteotomy to improve coverage. So medial displacement osteotomy. This 7 years follow-up, no pain. He has good range of motion, mild lurch. He is able to squat and sit cross-legged. Here he is walking. And he is able to squat down. This is an exceptionally good result. It doesn't occur every time we do trochanteric arthroplasty. Now, different authors from the review of literature, we find that most authors recommend that you do it early. If you wish to do it as early as you can so that there is good adaptation between the trochanter and the acetabulum. The other treatment option is a sham angulation osteotomy. It's a good treatment option. You have a situation like this, a group 2 hip, and you could do a sham angulation osteotomy and a lengthening. So you can do lengthening, you can get the length, you can get the stability by doing such type of a procedure. The next is the Ileozano hip reconstruction, and here you can actually angulate the upper femur by means of a Ileozano apparatus, do your osteotomy, angulate, and get a corrective osteotomy in the distal part to maintain the axis of the limb. And this is a good option. It abolishes vertical telescoping and instability. It decreases the Trendelenburg lurch, and it provides a stable fulcrum for limb lengthening. Ileozano hip reconstruction can successfully correct a Trendelenburg gait and simultaneously restore knee alignment and correct lower limb length discrepancy. So all this is possible when we do a Ileozano hip reconstruction. So when we do such osteotomies in young children, it's advocated, many authors advocate that you do it at a young age so as to maintain your abductor mechanism with proper length. When you do them early, they will remodel, and you see what is happening within a year. There is a fair degree of remodeling. So you may need to repeat these procedures very often. What are the other options? Well, bacillary critical iliac grafts have been used. Cheng used this in 1995. So he takes a branch of the external iliac with the iliac wing, part of the iliac wing, and notches it into the upper part of the femur and uses this. And you can see the extra pictures there. You can see reconstitution of the femoral head in these cases. You could use an ordinary fibula. The fibula is used here for reconstruction. And you can see that it turns into a spherical femoral epiphysis. All these are different possibilities. So faced with this clinical problem, our solutions for instability of observation or reconstruction, one of the types which I mentioned earlier, and for shortening you have length restoration. Now what is important when we are faced with a patient with this sort of a sequela, we need to establish the group, we need to establish that the femoral epiphysis is absent, and then we tailor the management to that particular patient. And the most important is that early diagnosis is required and appropriate and aggressive treatment is necessary. Thank you.
Thank you very much, Dr. Joy. Now all the papers are open for discussion, questions and answers.
Okay, thank you, Madam Speaker. I thank you very much for speaking in that time. That's on 12 minutes. Now is open for question and answer session. And I want to limit the time because we are running short of time. Any questions can be asked? Thank you.
Can I first ask Ashok? Ashok, you said that these scores are pretty good when you leave the patient alone. And so what do you think of the option that you leave them alone till 20 years to 22 years, they're quite okay, and then do a total hip replacement?
Yeah, it's one of the options, but there can be problems because the whole limb becomes very atrophied. The femur becomes atrophied, and joint replacement surgeons can tell us better, Even the actor loses it better, You need to bring the shaft down. You will have difficulties in stem fixation, you will have difficulties in cup fixation. So it's possible, but I don't know really the answers. We don't have comparative series.
Yeah, my
question to Dr. Karpa. If a 7-year child who has been treated and he got the fixed relapse deformity, what treatment he suggest?
Dr. Agarwal, incidentally, I mentioned in my talk that we restrict to under 5 years and then very supple food so that we do not have a bias on other situations. But the question is, it's a fixed food. Even if it is a fixed food, after 7 years, we will try to do some kind of manipulations into those foods to get a little bit of reduction. Right, being a person may a little bit of flexion. If necessary, you go ahead and do tender in those cases. Make the patient walk about over a table, and then later on, when it becomes a little more dynamic, probably one can go ahead and do a little bit of tender transfer. I know what the point you are hitting at. Those cases, probably you can go ahead and do either if you are experienced on that.
Yeah. Because basically deformity is the adduction deformity. That is the point. So first of all, we have to correct the adduction deformity.
Late cases, there are so many other problems associated with. Number one, that bone almost gets deformed by the age it reaches 7 years.
Yeah.
So it's not to get a corrected food, but to get a plantigrade food so that the child can walk. But this case is recurrence is very high, and then other sort of surgery also can help in those cases.
This is entirely rotation osteotomy. It's a technical problem. What do you do with the abductor and the IOACON situations?
In which osteotomy? Sorry, I didn't get you. Which osteotomy?
The Israeli rotation osteotomy.
Yeah. You will need to actually reattach that. You will have to reattach. You take a small slice of bone along with it and reattach the trochanter. Reattach the abductor musculature.
Dr. Johari, very good presentation. Age old problem. Ultimately, they lead, all of them they lead to arthritic changes and painful joints, deformity and shock, which you said very correctly. My point is, other than an arthrodesis and a girdle arthroplasty at the final stage later on in the life, have the joint replacement people done any advancement in this, and which type of a problem is more suited to the THR later on, if at all it has been attempted?
Well, I think we must realize that septic arthritis is a very heterogeneous group. So you will have presence of the head in certain situations. The type 4 or the group 4, you have femoral epiphysis present. The head is large, could be small, could be varus, polyps, etc. All those deformities take place. That situation is very different from a situation where you have the femoral epiphysis absent and you have an excision arthroplasty type of effect. So people reporting the results have not, dealt with each of these groups. They have reported the results for the type 4, for the group 4 cases. So where you have a femoral epiphysis present but the joint is arthritic and they have replaced, still there are problems of early loosening. When you are faced with septic arthritis, because the shaft is atrophic, they have difficulties in fixation. Because the abductor mechanism is not normal, you can have problems of abductor insufficiency giving rise to loosening of the processes, and you could have reactivation of infection. There are a few series which actually state these complications.
Any other question?
Dr. happy that you have a global outlook and nothing in Bombay. I have one question. That MRI in 2003 saw the light of the day. Before MRI, you did 70, 90. Now the MRI we did periphery of India. MRI is only requiring investigation. Should we wait for the diagnosis more important than that? When I know the principle, you can have one ideas. You tell me, before 2003, patient with other imaging. Now after 2003, with MRI. Should you go for all cases of MRI or you have imaging for it?
No, that's the reason I put up the play X-ray science which can tell you whether the femoral epiphysis is present. In young children, you can also do ultrasounds, you can do arthrograms, so there is a lot of ancillary ways, But MRI is the most sort of elegant way of demonstrating what is happening at the upper femur. But if you don't have it, you can still come to a diagnosis as to whether the femoral epiphysis is present or not.
Running short of time, please. Last question will allow.
Sir, to Dr. Johari, sir, as the statistics you said about when the hips left alone, sir, it's here. Hip lefts alone would be having a score of 74 versus operated upon have got 94.
No, it's the other way around.
If this is what the situation, would you like to leave the hip for some age? What is that age group for type 2? When should you get into the hip and operate upon, or should you leave till the age of 18 and go for THR and different options? What is the age?
Well, my personal preference in this particular group is to leave them alone or to go for a pelvic support osteotomy. One of those two options actually I follow, depending on what the patient wants. If the lurch is too much, we go for a pelvic support osteotomy. I'm not a great follower of protentric arthroplasty. As you would have seen, those cases are all courtesy, because I don't actively manage group 2. My personal preference is to leave them alone, based on the analysis of results which I carried out.
Can you demarcate the age at which you would like to do a pelvic support osteotomy in these cases?
Yeah, I actually, following modern literature, we tend to do them early. We could even do them at a young age, like 5 or 6 years, and then repeat it. Ideally, you would be near to scheduled maturity. But there have been some people which say that gluteal atrophy is very significant if you don't do anything for them and you wait till skeletal maturity. The abdominal musculature actually wastes away and is not as efficient as when you do an interval pelvic support osteotomy. And that's the reason for doing it in between. It will gradually remodel whatever effect it gives that helps the abdominal musculature to be maintained.
Yes, Professor Jha.
Well, Dr. Johari, there are reports that in absence of capital femoral epiphysis, distraction can regenerate the capital femoral epiphysis.
No. I think this needs to be proven. If it is not there, it is not there. You just can't do distraction and regenerate. If you have an unlock which is present, maybe you are able to distract and elongate it, But if it is not there, nothing will happen.
Well, I am not aware about capital femoral epiphysis, but there are reports that in case of pyogenic arthritis of the upper tibia in children, regeneration has taken place for
Because the cartilage is present, because the unlock is present, there can be regeneration. No question. We have seen that even in this case, which I showed you of the patient in whom we did an MRI. He saw the head after a few months, Sometimes you see them after 4 years, 5 years and 6 years, But basically the head is present. If you were to do an MRI, you would find that the latch is there.
So finally distraction should be done or should not?
I don't think it has a role in this group 2 type of cases.
Well, last question to from this table, Professor Nilakant Das, from the unilateral leg presentation at the age of 12 years. What should we refer to do? Whether live like that or for any surgical procedure?
The situation demands. As because in unilateral hip dislocation, the complication rates much more. So, if it is possible, it should be done. I personally prefer to do it even at the age of 15, 16 years.
Thank you very much. Since we are coming to
It should be around 10 years. After that, we should take decision carefully.
but in bilateral cases you are told
Bilateral cases, definitely after 10 years, we should not proceed for surgical intervention.
unilateral you will go for surgery.
Yeah.
Right, thank you very much.
Thank you very much, the speaker and the audience. There is no limit for discussion, but we are bound to limit discussion question answer because of the time constraint. Now I will request all the speakers one by one to come and take the moment group. Dr. Cme T2. Next, Dr. IOACON2013. Next, Dr. H.P. Das. And last, Dr. Ashok N. Joy.
And for other persons, I would invite Dr. Anup Kare, present, a memento to Dr. Sanjay Das. And Dr. Ashwini Sadana will come forward for a memento to Dr. S.C. Sahu. Thank you, sirs. Thank you for keeping time. Lovely discussions. We go on to the next session, and that is decision making in spine disorders. I would invite the chairpersons for this session, Dr. M. R. Mahapatra and Dr. Santosh Rajpal, sir.
Morning, everybody. The time is running short, so I will give a brief introduction of the speaker, and the time given to the speaker is 10 minutes. 12 minutes. 12 minutes. The first speaker is Dr. S. Rajpal. Our past president, he doesn't require any introduction. He has unmatched academic achievement and was many most notable being the Hungarian innovation. Dr. Rajpal.
Thank you, sir. Good morning to all of you. In 1948, Dexter and Bart described the disc collapse and then started the beginning of the disc dynasty. From that time, every decade, there are 10,000 more of disc replacements, disc surgery that are being done. And surgeries are done in the US alone every year. Most of us get entry into spine surgery through the lumbar disc surgery. But however, if you carefully look at the literature, the results are poor in up to 10 to 30% in various series. And unfortunately, re-interventions after primary discectomy can be up till 18%. So the traditional book teaching is that you have to have the McNabb criteria right if you have to get your good results. The clinical symptoms must be classical. It should be matched by investigations, and there should be a good clinical radiological correlation. And then your satisfaction rate can be up to 90%. However, clinical practice is not very clear and is never a clear-cut black and white. And so for the beginners here, I would just discuss 6 or 7 salient dilemmas that you get when you start your practice. Number 1, are all disc prolapses that are seen in MRI, do they require surgical treatment? Well, if you see here, a typical example, a 42-year-old male, first episode of moderate pain, comes into the clinic with a large disc prolapse seen, and does it require treatment? Now, if you look at this, we know that MRI is the most sensitive. It shows lots of disc prolapses, lots of changes, lots of black disc, lots of degeneration. But it is not always indicative of a disease because it has very poor specificity. Now, in one of these most quoted studies, 98 asymptomatic volunteers who had no back pain were given MRI, and they were all below 60 years. You will find that only 36% of them had normal intervertebral disc. A single disc bulge was seen in 52, and some sort of abnormality was seen in more than one level in 38, which means that there can be a lot of spurious MRI finding. If you get to a population which is above 60 years, you find that up to 79% of the people without any symptoms have a disc bulge, and 21% have a spinal stenosis, which means that the lesson that we have to take, all positive MRIs need not be operated. there is no role also for prophylactic spinal surgery in our current practice. It also holds true even when the McNabb's triad is normal and if the patient has just got a first episode pain. I would just like to take this one single example and carry on with a few controversies which you may have a problem. A 26-year-old student comes with a very large disc prolapse which has extruded and migrated. First episode of pain of 2 days, classical radiculopathy, SLR is this, and paresthesia of L5 dermatome. And this brings a few basic dilemmas in our management. Does first time episode require surgery? What is the duration of symptom before you should operate? Severity of pain? Does large extruded disc and migrated means does it need surgery? And does a sensory disturbance and a EHL weakness amount to neurology? Now this is also very well reported that when they saw people with large discs and they were treated with bed rest, they noted that 80% of patients had major improvement within 6 weeks, and at 12 weeks there were 90% and that 93% had an excellent result at 24 weeks. Again, another study which shows that out of the 58%, 87% of patients had excellent or good results irrespective of the presence of a minor neurological deficit. So, a clinical trial of 3 weeks of conservative therapy did not cause a major deterioration or problem in any one of them. Further, we also know that the natural history is one of resolution. So here you can see a massive extrusion which is so frightening. After a period of conservative therapy, a repeat MRI at the end of 6 months shows that the complete resolution of the disc prolapse over here. So the verdict again is the size of the disc should not influence the decision of surgery, and type of herniation may have an influence on but should not divert a conservative trial. So a conservative trial is the default pathway, but duration again is very important. So you can't put these patients to bed rest for a very, very long time, and we'll come to it. What about EHL weakness and great tone numbness? Almost 90% of the time, spine surgeons used to convince the patients into surgery onto the operating table by demonstrating a EHL weakness. However, both these excellent articles, the review article and also is looking into specifically, they said minor neurology should not influence a decision on treatment, and no proof that a EHL weakness will progress to foot drop. I think this is very, very important. No proof that a EHL weakness will progress to foot drop, and only major deficits require earlier intervention. So again, the fourth verdict is tibialis anterior weakness and foot drop require immediate surgery. However, a mild EHL weakness or sensory disturbance does not warrant surgery, and conservative management will be very good. So when you say conservative treatment, bed rest for what duration? Few days, few weeks, or few months? Now this study again has proved that the chances of resolving the symptoms with conservative care decreases progressively with increasing time. After 3 months of continuous or almost continuous, the chances of improvement are very slight, and there is no improvement after 6 months. So if a patient comes to you, immediately you offer conservative therapy. But if he has already had all physiotherapy, bed rest, everything for more than 3 months, then it is not correct to put him further on conservative treatment. Again, this is another study which says that the conservative therapy should be less than 1 month, and putting them on a prolonged conservative therapy is no good. During this conservative period, do you use belt and braces? The Cochrane review and all other studies have proved that traction, belt and also intermittent traction is got no scientific basis, but if you want to use them as placebo, you can use. Another important decision making. It is now very common that patients walk into your clinic with just an MRI and they don't have a plain X-ray. This is very, very common. Should you do a plain X-ray when you already have an MRI? You should certainly do it before, especially if you are contemplating surgery, because spondylolysis like this is sometimes never seen. And the worst thing that you can do is to go and do a discectomy without addressing this problem, and you will cause an increased problem. Plain radiography also shows other things like instability and disc space changes, which may make you decision regarding whether you are going to fuse or not. Lastly, what about diagnostic mismatches? When you have a bilateral compression and you have unilateral symptoms, Or when you have unilateral radicopathy, but MRI shows contralateral disc herniation. Should you operate on the side of the disc or should you operate on the side the patient has pain? Or if you have unilateral problem, should you decompress bilaterally? Although the decision is not very clear-cut in literature, I think for the Indian patient in whom a second spine surgery is a big taboo, it would be much better to operate and decompress on both sides. Both of these can have a microdiscectomy and that is not a major problem. When you have a radiculopathy but MRI reveals no significant neural compression, make sure that you have not missed a far lateral disc, because this syndrome is often missed in reporting even by radiologists. So you should always look at far lateral disc, and that is the problem. Secondly, if you have another patient who has a failed back syndrome and has pain, make sure that you identify all causes of problem over here. Now here you can see that this patient came with failed back syndrome, but the actual problem that he has is a very large aneurysm of the aorta over there, which was causing him severe back pain. It would be terrible if you mix this and then go and do another surgery on him. So once you decide to operate, which method? Fenestration, microdiscectomy or endodiscectomy. Now literature shows that there is very little to choose from all these three. At the end of 3 weeks, a well-performed fenestration or a microdiscectomy or endoscopic discectomy have nothing in advantage to each other. Percutaneous discectomy is of course very controversial and has got a relapse rate of up to 46% and hence is not a major prior knowledge. So the last slide is, if you have to have a success in this surgery, please remember that you have to have the McNabb's triad right. The clinical symptoms must be there, radiculopathy more than back pain. Investigations must show a good disc, and there should be a clinical radiological correlation of the side and site of pain. Now, although it is the most common surgery, it is also the most common cause for failed back syndrome. Literature shows up to 20% of poor results, patient dissatisfaction, and 18% of reoperations. So we need to take this very carefully. Thank you very much for your.
Please take your seat, Dr. Ramsad. Please take your seat there.
The next speaker is Dr. Jaiswal, Arvind Jaiswal.
To look back to the posterior elements, there is a defect there, a lysis there, which would become obvious if you do an oblique view, the typical Scottish Terrier appearance, and you would need to then do a flexion extension, the dynamic views and the lateral view to establish the instability there. If you look at the Wiltshire and Newman's criteria of the type of spondylolisthesis, our patient would fall in the isthmic variety with a lytic defect and with probably an old stress fracture there. If you look at the three main spondylolisthesis that you have, the dysplastic, isthmic and degenerative, you need to look very careful even on plain X-rays. The posterior elements would show a defect in the form of a lysis or an elongation of the pars as compared in dysplastic and isthmic. In degenerative, of course, the defect in the posterior elements will not be there, and you would need to get an MRI or a CT then to delineate that. And the defect is mostly in the subluxation of the facet, degenerated facet, the capsular laxity, and thus the slip which will happen, the progression would not be to that extent. It will stop short at 1 or 2 grades, whereas the dysplastic and the isthmics would progress very rapidly on to become more advanced stages of slip. Now, if you look at the dysplastic particularly, you've got to look at the basic structure. The dysplastics have a dome-shaped telltale sign of a dome-shaped S1 and a wedge-shaped L5, the trapezoid L5. Now, that should put your alarms ringing that these are dysplastic ones and these are the ones which are going to progress very rapidly. So that brings us to the grading, the Meierding's classical grading into type 1, 2, 3, 4, 25% per grade, and our patient falls obviously in the grade 2, 50% slip. Now it is very pertinent, and it has a lot of talk has been going on the sagittal profile of these patients. So all spondylolisthesis patients now have to be x-rayed in the whole spine standing view, and that gives you an idea of how the spine is balanced on the pelvis. The spinopelvic parameters are being talked of. Due to time constraints, all that I say is that pelvic incidence, sacral slope, pelvic tilts needs to be evaluated to look at the balance. And based on this, the newer classification of ST-SG classification has come up. And our patient would fall somewhere in the low growth variety here, probably a high pelvic incidence, and which would then sort of guide you that this is the case which is likely to progress very rapidly. Amongst the high grade grade listhesis, you see there is a criteria of balanced pelvis and unbalanced spine. The last criteria, the unbalanced spine patients, are the ones which you would now need a fixation and as well as reduction. What about MRIs? We would normally do an MRI if you're going in for surgery, and as you all know that the MRIs give you an idea of what the stenosis is like, what is the neural structure like, and the state of the degeneration of the disc. Interestingly, if you look at the ischemic spondylolisthesis, a low-grade ischemic spondylosis, there's actually an increased anteroposterior canal diameter there, but the patient has leg pain, so the stenosis or the constriction is only in the lateral part, in the foraminal part. As compared to a degenerative spondylolisthesis, this evidence of canal stenosis, ligamentum flavum in the central part as well as in the lateral part. So that brings us to the method of management. A good trial of conservative management is the answer. However, when you have these low-grade ischemics and developmental, you should have a close observation of these. If the pain goes away, then obviously you just observe them. However, if the progression of slip under observation occurs, then you need to operate. Or if there is a failure of conservative treatment for the intractable pain, radical symptoms, then you need to go in and operate. Simplistically, what you do for the leg pains and neurological claudication, you would need to do a decompression. For the back pain, which is primarily due to segmental instability, you would need to fuse it. Instrumentation added improves the fusion rate. What type of fusion? Posterolateral fusion, the old trans-alar fusion without instrumentation had a very high pseudarthrosis rate. With instrumentation, it is cut down, but still a rate of a high incidence of pseudarthrosis is present. Anterior lumbar interbody fusions have been tried. Stand-alone gives a very high pseudarthrosis rate. So the present criteria, the present treatment option is the global fusion with instrumentation. Single level fixation with pedicular screws and interbody fusions sort of gives you a good fusion range. Besides, it allows you to save important lumbar segment motions. So that if you fix even with pedicular screws and do a posterolateral fusion, you would have to probably take another extra lumbar segment, and that's important. So you aim at having a 360 fusion with an interbody laser. I'll take you to the second type of cases. Now this is an elderly lady, 56. The first case, the ischemic ones present earlier, young adults. Now these are elderly ladies with degenerative changes, and as I said earlier, the posterior element is very much preserved, and you have a local stenosis at the MRI pictures. Now these have to be tackled as lumbar canal stenosis, and majority of them respond with conservative treatment very well. About 80% would not need surgery as such. A very few of them who would not respond to conservative management with pain and radicular symptoms persisting would need surgery. And surgery is in the form of decompression primarily, but people earlier would do just decompression without fixation. And there is evidence that about 30% or more have unsatisfactory result. Because once this is a relatively unstable situation, and if you further decompress, it becomes more unstable. So the trend is to fix them after good decompression and do an interbody fusion with a good fusion. All this can be now done by minimally invasive surgeons, by minimally invasive surgery, percutaneous fixation, and going in a tubular retractor to do your interbody fusions. And this is what we normally do for the low-grade listhesis, either ischemic or degenerative. Now, this is an interesting group of cases. Patients with spondylolisthesis, young age group, presenting very early as an adolescent. And if you look at these, the telltale sign of a dome-shaped S1 and a trapezoidal L5 will give you an idea that these are developmental type of marchettes or dysplastic ones. Now, these are the cases which are totally different. They are asymmetrical growth development abnormalities, similar to Brown's disease of the knee and stiff capital femoral epistaxis. They have complex spinal pelvic deformities, have sagittal plane imbalance. So if you look at the biomechanically, the line of body weight bearing shifts more interiorly with the increased rate of slip, as a result of which the body tries to bring it down. So the lumbosacral kyphosis is there. When you try to bring the weight down, the pelvis tilts backwards, the sacrum becomes very, very vertical, and the patient lands up with a crouch stance and a crouch gait. The increased hyperlordosis above the lumbosacral area. Also, when you look from the back, there's a trunk shortening. Because of the torso going anteriorly, when you look at the back, the alignment of the trunk is very altered, and you have the gluteus staring at you as a heart-shaped deformed pelvis there. And the hamstrings are tight. As I said, these present in a pediatric age group and a totally different ball game as such. And they should be seriously looked at as deformities. Also, because of the severe stenosis at L5S1 recent, there's leg pain and there's mechanical back pain, and these have to be treated. And even the low-grade dysplastics can be treated conservatively, but you have to be very careful, look for a slip later on, and once they are progressing, they have to be fused. In high-grade slips, grade 3, grade 4, and grade 5, you have to resort to surgeries. The question is you need to decompress, but the controversy is when you need to have an in-situ fusion or you need to reduce and fix them. Now, the standard procedure, the posterolateral fusion with the Gills procedure, gives a very high rate of progression.
Jaiswal, your time is out.
Yeah, okay. So you need to fix them up, either reduction or by in-situ fusion. I'll just take 2 minutes, sir, with your presence. Reduction corrects the deformity and resolves the crouched feet gaze. However, very technically demanding and high neurological deficits. But there are papers, there is the SRS spine spondylolisthesis summary group which says there's a compelling rationale to reduce it. If you have the means, if you have the skill, by all means do it and you'll get good results. Especially in these high-grade listhetic patients, they do well and they correct well, the alignment is good, the deformity is corrected, and the sagittal balance is reduced. And now with good techniques and with root monitoring, the neurology is reduced to a so basically, in summary, these are the 3 different kinds of presentations in listhesis, and you've got to look at it, and the dysplastic ones has to be treated with respect and with specialized thing. Thank you so much for your patient hearing.
Thank you, Dr. Jaiswal.
Please take your seat, please.
The next speaker is Dr. H.S. Chabra. Dr. Chabra will be speaking on spinal cord injuries. Dr. Chabra is the Chief of the Spinal Services and Medical Director of Indian Spinal Injuries Center, New Delhi. He has expertise, is grounded by more than 20 years of clinical and academic experience as an orthopedic and spinal surgeon. Has published 31 papers, including 10 full-length chapters in leading textbooks, and has undertaken 18 major research projects. Was awarded Order of Star of the Italian Solidarity by the President of Republic of Italy, Deputy Prime Minister, and Minister for Foreign Affairs in 2007, among so many other awards. Dr. Chabra, please.
Thank you, sir, for your kind words. Respected teachers and dear colleagues. Over the next few minutes, we'll be talking about a devastating ailment, spinal cord injury, which had been initially described as an ailment not to be treated. And in the First World War, 90% of the patients died within 1 year, and only 1% survived more than 20 years. However, during the Second World War, two stalwarts revolutionized the management of spinal cord injuries. There are few things which are important to understand when we try to discuss about decision making in spinal cord injury. The first is that there's a lack of inherent ability of neurons to regenerate effectively for functional improvement, and that's why if an injury is complete, it tends to remain complete for life. So how do we define a complete spinal cord injury? If there is absence of any sensory or motor function in the lowest sacral segments, that is S4-5, if there is no perianal sensation or voluntary anal contraction, you define it as complete injuries, and 99% of them will not improve with time. Whereas if there is any preservation of these functions, it has likelihood to improve with time. Most of them, in fact, do recover. As spine surgeons, there is tendency for us to try to think that surgical management is the most important component of management of spinal cord injuries. But if you can see here, it just forms a small component of the acute management. And that is where we need to focus our attention also on. Spinal cord injury management requires a multidisciplinary team approach. The surgeon or the spinal injury consultant forms one member of the team. And if we were to think of the most important component of management which can influence spinal cord injury care, the experience from the Western world has shown that it is pre-hospital care which is most important. In US, they showed that implementation of this reduced the mortality rates and complete injuries drastically. Now, how you extricate the patient at the site of accident also depends where the injury takes place, whether it's on road or in water. Also, we need to keep our eyes and ears open to try to recognize the injury, because very often they get missed in polytrauma. So, if there is a suspected extremity fracture or neurological deficit or spinal pain and tenderness, one should suspect it. One should immobilize the spine carefully. The current recommendations suggest that one should have a rigid cervical collar, lateral supports, and tape and body straps to secure the patient to a backboard to protect the entire spine. One should not try to remove the helmet except if it tries to hinder with the immobilization or with the resuscitation. And when it comes to pediatric spinal cord injuries, they are different, so they need a different mode of immobilization. What should be the mode of transport is also important, and the distance en route, the definitive center plays a vital role in deciding how you would transport the patient to the definitive institution. Imaging also, there are guidelines on what imaging to be done, where you don't need imaging. Of course, when you suspect a spinal cord injury, it's important to screen the whole spine because there is often multiple injury. When it comes to how you manage the vertebral fracture, there is no clear-cut consensus on whether conservative or surgical management has a definite role in this. In discoligamentous injuries of patients with polytrauma, impaired compliance, surgical management may be advisable. Centers should be able to offer both management at all times, and there is a need for a prospective randomized blinded study. This is the consensus amongst the experts worldwide. Now, when do you go in for the surgery? Again, there is a debate. There has been a recent study which showed that if you go in early, you may have better outcomes. And with modern day resuscitation and anesthesia techniques, people are feeling more confident to go in early for spinal cord injury management. However, because often there is a polytrauma associated, you should go in only once the patient is stable. Because if there is any element of hypotension or physiological instability in the patient during the surgery, it will compromise the ultimate outcome much more than the stabilization or early mobilization that you achieve. Again, when it comes to polytrauma, there are good studies which show that you should go in for an early intervention. One may, however, try to modify the intervention. For example, if there is a thoracolumbar burst fracture which also requires an anterior reconstruction, one may just go in for posterior percutaneous stabilization and leave the anterior instrumentation to a subsequent time. Now, when it comes to role of steroids, there is again a controversy, even though there were some trials which showed that there were a definite role for the steroids. There is a need for a double-blind, randomized controlled study. However, till such time, one may offer it to all patients who come to the center within 8 hours of the injury. When it comes to whether you go in for conservative or surgery, there is a thoracolumbar injury classification score which one may use, where you consider the morphology, the integrity of the posterior ligamentous complex and the neurological status. If the score is less than 4, you go in for conservative management. If it is more than 4, surgical management may be required. Let's say this patient who has a complete injury, here the score would be 9, hence this patient needs a surgery. When it comes to long versus short fusion, the current recommendations are that we could go in for a short fusion also in the thoracolumbar motion and the thoracolumbar region, and this is important because a short fusion helps the patient in retaining rotation, which is very important if the patient is to be confined to a wheelchair. Again, we also put screws at the fractured level in order to try to achieve reduction, and we try to use big diameter screws. Now, when it comes to burst fractures, if they are stable burst fractures, there are enough studies which show that they can be managed conservatively. They behave differently than the other fractures which are there in the thoracolumbar spine. However, if you need to go in for a surgery, whether you need an anterior reconstruction or not, you can come to a conclusion to that with a gain score. So if the gain score is more than 6, you would need an anterior reconstruction, and if it is less than that, you may not need an anterior reconstruction. Here's an example of a thoracolumbar burst fracture just managed anteriorly, and another one which was managed initially posteriorly and then an anterior augmentation was done subsequently. When it comes to minimally invasive spine surgery, it has a definite role now, especially in polytrauma patients where you may want to maintain the physiological stability of the patient, so you can percutaneously fix the patient and go in for augmented procedures subsequently. Also has a definite role in old patients and those with comorbidities. However, there is more radiation exposure, and because you don't do the fusion in the initial stage, you may need to remove the implant subsequently. Now, when it comes to cervical fracture dislocations, the management depends on whether there is complete or a partial deficit. If there is no or partial deficit, one may go in for an MRI, and if there is a disc, you may not go in for a closed reduction and go in straight to the theater. If there is no disc in the canal, you may try to achieve a closed awake reduction, as was done in this patient, and then later you can just go in for fixation with an anterior approach. However, if you can't achieve a reduction, then again the decision depends on whether it's a complete or an incomplete injury. In an incomplete injury, one may want to remove the disc from front before you go in posteriorly, reduce the fracture, and then go in for a fixation, as was done in this case. A neglected spine trauma is a common scenario, and this would change your decision making because very often the patients would come late after the injury. Now, it doesn't stop at that. As we discussed before, what kind of bladder management should be done, also what kind of sexual rehabilitation should be done. Of course, most of them resort to drug management now, and then 50 to 60% of them can have success with fertility. Rehabilitation, of course, again should be conservative, physical, psychosocial, sexual and vocational, and what should be your goals should be determined in consultation with the patient and the family. And it's, as we talked about before, the rehabilitation requires a big team, and without comprehensive rehabilitation and integrating the person back into the community, you have not achieved much. And of course, in the end, the dictum prevention is better than cure has special relevance for spinal cord injuries. Thus,
Dr. Chabra, your time
it's a devastating ailment, but an appropriate decision making at each step of management can help you in achieving, maximizing the outcomes for these spinal cord injury patients. Just a word, www.elearnsci.org is a wonderful web resource which any of you can use free of charge to gain any information on comprehensive management of spinal cord injury. It's not only for doctors, but all health professionals, whether nurses, therapists, social workers, psychologists, or policymakers. Thank you for your attention.
Please take your seat there, Dr. Chabra. Now, Dr. Shankar Acharya, a senior consultant in orthospine surgeon in Sar Gangaram Hospital. I am proud to say that he was my student in SB Medical College, Cuttack. He has worked in Edinburgh University as a clinical tutor and has worked in so many places. He is the past chairman, IOACON India, and secretary, Delhi Spine Society, recipient of several fellowships, including Manor Levine Spine Fellowship. Here is Dr. Shankar Acharya.
Respected seniors and my friends, my job is to talk to you about failed back, and it's a very important aspect of spine surgery because these are the patients who've had surgery before. And in order that you have a less small percentage of patients who have failures, it's very important that you know the principles. So I'll tell you the principles and then take you through some cases. There's a lot of advertisement that it's disc surgery is band-aid surgery, it's percutaneous surgery, you come in and go out. So, but it's very important to understand there's no such thing as a little operation, and every operation has complications. And failed back surgery is defined as persistent recurrent pain, mainly in the region of the lower back and legs, even after technically successful surgery. When everything seems perfect and still the patient complains or something doesn't seem perfect, then you can say it's failed back. Why does that happen? Every surgery that we do as orthopedic surgeons must be predictable, must be easy, must be reproducible, and should have at least 90 to 95% good outcome. In spite of that, why do we have so many failures? I think the problem lies in the combination of these. You get the wrong patient, the surgeon does the wrong surgery, the disease is something which you never understood well, and the procedure was probably right or wrong. So it's very important. Because of these, you get a higher percentage of failures. So what are the causes? Choosing the wrong patient, arriving at the wrong diagnosis, choosing the wrong operation. During surgery, technical errors, surgery at the wrong level. This is also very important. Inadequate surgery. And then post-operatively, you have infection and arachnoiditis, epidural fibrosis, dural tears, etc., which are big problems to solve. This is something you have no control on. Some of these patients fail because of other problems. And diabetes, spinal muscle deconditioning, autoimmune disease, these are also important things to have an aspect, because sometimes I have patients who have everything perfect and still they fail. And if you really look into the perspective, 50% of failed back got it wrong, the surgeon got it wrong. How to approach a patient? Since this is a CME, I said how to approach a patient. You identify, take a good history examination, investigate thoroughly, establish treatment, patient counseling, revision surgery only if you can find a cause. Go back to the beginning, make the story together, approach as if, so go through everything. Don't go with a fixed diagnosis. What comes, you get loads of loads of files, so don't go with a fixed diagnosis. And make contact with the previous surgeon, become his friend. Complete neurological assessment, examine other joints. Dr. Rajshekharan just showed one with a aortic aneurysm, and that was the cause of back pain and not the disc. And try to find other causes. Investigate properly. And the purpose of the investigation is this threefold. Residual of previous problem. Whatever surgery you have you done it wrongly? Is there a problem with that? New problems that may arise, like arachnoiditis, fibrosis, implant failure, infection, wrong implants, wrong placement, things like that. Or is there another pathology which you completely missed? This is, I think Dr. Rajshekharan showed far lateral disc. And this patient had a discectomy through a traditional approach, and you can see he had a discectomy and the disc was still there and he was in severe pain. And he had a repeat MR which showed that the pathology persisted, so the surgeon didn't do the right thing, so that's why it failed. So he had to have a repeat surgery. And this is a big surgery. From a small surgery, he should have had a Wilsey approach. This is a patient with a disc prolapse, and I think all of you would agree that they would do a discectomy following failed conservative treatment. And that's what the surgeon did, and he did a wrong level. And he caused a dural leak. So he ended up with a big problem. So it's very important in this case to get the right level. This patient sued the doctor, and ultimately the disc resolved, so the patient was all right, but it's not the right thing. It's very important to get right level, even if it's a small surgery. Post-op discitis, don't ignore, because a lot of times we don't advise post-op MRs, even if the patient has fever, pain, and everything is not settling. So have a high index of suspicion, and if it is your case, then recognize that. This is percutaneous discectomy, transforaminal, and he ended up with gross discitis, and the surgeon said nothing can go wrong, I have done through a small hole, so he needed a major fusion, and so that's important. These are more technical. This is a 3-4 fusion, 4-5 fusion which had a junctional problem, and so they